Assalamu alaikum wa rahmatullahi wa barakatuh. This is Dr. Ahmed Samir from Cairo University and Magdi Al Foundation, Egypt. I'm happy to share my case with you, stumbling few millimeters before the finish line in an LAD CTO. My patient was a 58 years male, ex-smoker, hypertensive. He had history of acute coronary syndrome 3 years earlier. No angiography or revascularization were performed by then. And he recently started to present with crescendo angina. He went for another facility where he had coronary angiography and attempt of PCI to tightly calcified LAD total occlusion. He has a dominant left system, and the disease from the LAD obviously started from its ostium. And a small diffusely diseased right coronary artery. The colleagues there started with a PT2 moderate support with a balloon to support the wire, but the proximal cap proved to be impenetrable, and they aborted at that stage. We scheduled the patient for an appropriate CTO setup, pushing for any retrograde collaterals to obviate the need for repeated antegrade injections. I cannulated the right coronary artery, the non-dominant right coronary artery, but it was very disappointing. There were no retrograde opacification of the LAD from the right coronary side. However, from the starting of the procedure, the LAD calcifications were quite impressive. We delivered a Corsair Pro into the proximal cap and performed a tip injection. Obviously, we had two branches at the proximal cap, a diagonal and a tiny septal perforator, while the LAD presumably in the middle between the both of them we did not opacify at all. We started hoping that a fielder XTA could engage any microchannel, but it was either prolapsing into the side branches without engaging the CTO proximal cap. So we escalated up to a Conquest Pro 12 in an attempt to puncture the calcified cap, and then we should de-escalate. However, we did not have the luck to overcome the calcifications at the proximal cap. Obviously, what was happening is that the fielder XTA could not penetrate and was prolapsing into either of the side branches, while the CP12 was being deflected by the calcium outside the vessel architecture, and hence we thought of switching strategies. So we switched retrograde. We served the septals with assign and assign black wires, but could not reach the LAD. Septals led to everywhere except the LAD, and a tip injection was not very promising. And the only single connecting septal that we could find reached the LAD, but in the proximal LAD, proximal to the site of the CTO. So we went back to the antegrade, now with a Gaia third, and with some manipulations, the Gaia could cross into the distal true lumen of the LAD. When we were trying to advance the Corsair microcatheter, it was hardly advancing because of the extreme friction with the calcifications at the proximal cap. However, we started to dilate initially with a 215 compliant balloon, and unsurprisingly, we had a long dissection in the middle AD. However, we had to ascertain that the stents will expand well, so we ensured a 3.5 by 12 non-compliant balloon inflated at 1:1 sizing with rotational angiography. Now we were proceeding for stenting, and we planned initially for a 348 designs expedition that was implanted in the mid-LAD. And with the same balloon, we used it for sizing, and everything at this stage was looking very good. However, we noticed that the diagonal branch was suffering. So we performed kissing balloon inflation with the already placed 348 in the LAD and a 215 compliant balloon in the diagonal origin. And after that, the diagonal was very good, and we planned for implanting the second stent. The second stent was a 3.548 Zines expedition from the left main ostium to the mid LAD, and it was deployed very nicely. Then we optimized the overlap at 18 atmospheres. Although we were presuming that we were a few millimeters from the finish line, but the patient yelled of acute severe chest pain, and a quick shot revealed that we had a heroic extravasation, and the hemodynamics showed extremely rapid deterioration. The first response to a coronary perforation was as followed. We inflated an occlusive balloon at or proximal to the vessel injury and immediately started resuscitation with fluids and vasopressors as needed. We checked because if there is tamponade, pericardiocentesis can be life-saving to decompress the heart. We should inform the nearby surgeon. In many cases, the tamponading balloon occlusion can close to the perforation, but if extravasation persisted and it is refractory, then we have to find another solution like covered stent, embolization, or even emergency surgery. This exactly was what happened in the same stepwise approach. In seconds, we had an occlusive balloon to limit the extravasation. Meanwhile, echo appreciated a considerable amount of pericardial effusion. Resuscitation was already running on the other side, and we performed pericardiocentesis. Meanwhile, we were occasionally deflating and checking, and we were luckily enough to observe that there was a gradual reduction of the amount of extravasation. The blood pressure started to build up, and repeated checks were actually improving gradually. Now we had the courage to remove the occlusive balloon because the extravasation had stopped completely. However, we find that there are some filling defects at the site of perforation, probably the sealing thrombi, and the diagonal got greatly compromised because probably some of the thrombi were obstructing its origin. Although it was a good, at least safe status to leave, but we felt that a malopposed floating 3.5 stent in the LAD and the left main would cause the same problems as the we should not dream of. So we opt to optimize the proximal LAD and the left main with a 415 non-compliant balloon at high pressures. And that was a better picture to leave with, except for losing the diagonal completely. Monitoring the hemodynamics and echo, the day went smooth, and we brought the patient next morning. The diagonal started to reappear, and everything seemed good. So we optimized for the LAD further with a 4x20 balloon and potted the left main with a 515. That was the final angiographic picture, very acceptable. And we had TIMI3 flow in all the branches. And the final thing was to remove the pigtail under fluoroscopic guidance. That was the next day echo. It was very reassuring with minimal amount of pericardial collection, and the patient was safely discharged after 2 days. The key learning points that we had is coronary perforation remains one of the most worrisome complications in the cath lab and represents the second most common reason to rush to emergency surgery. Immediate identification and understanding of the etiology are keys for the appropriate management. First steps should be proximal occlusive balloon support the hemodynamics, assess for the need for pericardiocentesis, which if needed should be performed promptly. In many cases, prolonged balloon inflation can save the day, and if not, covered stents, coil fat embolization, or emergency surgery should be sought. Thank you.